first hour. As it's mentioned in the chat box, we will be recording this. So if yourself or colleagues want to watch this at a later date, it will be made available through the Institute of Development Studies YouTube account, and we'll be disseminating that on Twitter and LinkedIn and various places. But thanks very much for coming along today. Just essentially to kind of kick us off, I'll explain the agenda of today, and then I'll give a little introduction. So what we're going to do is we're going to start with a presentation of some of the findings from the Mozambique study, and then we're going to bring in our other speakers to speak about some of their recent research and some of the recent projects which we think are very relevant to this Mozambique study, to be able to give a little bit of context around different approaches. The way we'll do it is that each speaker will give a short presentation, and then we'll open up for specific Q&A related to whatever the speaker has been talking about. If it's a more general comment or question around kind of grievance stress or complaints mechanisms, we'll leave that for the session at the end, where we've got a longer session where you can ask questions to different panelists and ask to kind of hear different perspectives from them. So that's the way we're going to run today. As this is being done through a Zoom webinar function, you unfortunately won't be able to, as a listener, be able to speak or turn your video on, but you are able to communicate through the Q&A function at the bottom of your screens. So all you need to do is click on that, and myself and Ludo will monitor that, and we'll make sure that your questions come through to all the panelists. So just to sort of start us off today, the intention of today's session is to focus on grievance redress mechanisms, complaints mechanisms, examples of raising citizen voices and response from governments, particularly around public service sectors is the main focus. And we have examples from Mozambique, Pakistan, and South Sudan of that. Just to give a little context, as this is being kind of hosted from the Mozambique project end, which Ludo and I both work on. POTENCIAR, the Mozambique program, is a program which seeks to address accountability and governance issues which undermine the delivery of quality basic health services in particular, but general services in northern Mozambique. And we have been recently, over the last 2 years, doing a study on grievance redress mechanisms focused on the health sector and looking at some of the challenges and issues there. And Ludo is going to speak a little bit more about that in a moment. I'll introduce each of our panelists as I bring them in turn. But I'll also paste their biographies in the chat box, so you've got a chance to hear a little bit more about everybody. But I'll kick off first of all by inviting Dr. Ludovico Alcorta to speak. Dr. Ludovico Alcorta is the Research, Evidence and Learning Lead on the POTENCIAR program in Mozambique. His background is in research and learning across Southern and Eastern Africa, and he's going to speak today about the recent study conducted by POTENCIAR on GRMs in the health sector in Mozambique, and about what the program is going to support the implementation of the recommendations with government and civil society. Over to you, Ludo, if you'd like to share your screen as well.
Yes, thank you, Annette. Thank you, Annette. Can you see my screen?
Yes, your screen's up. Thanks. Go.
Take it to here. Well, welcome everybody, and thank you for attending this session. Very glad to have received such attention from speakers and experts in the field. I am going to present the study on grievance redressal mechanisms in the health sector in northern Mozambique. And before that, I'll give a little introduction on the program POTENCIAR to give a bit of context. So the program POTENCIAR is an FCDO-sponsored program that addresses accountability and governance issues undermining the delivery of quality basic services in Mozambique. POTENCIAR aims to contribute to individual, collective, and institutional changes that increase government transparency, accountability, and responsiveness to better resource allocation, more inclusive planning, and decision-making. We collaborate with various actors, including citizens, civil society, communities, service users and providers, as well as the authorities, to develop pro-accountability initiatives that are aimed at strengthening civic engagement and supporting coalitions of actors to improve the provision and quality of basic services. Whilst they cover different ranges of topics, they are focused on the health sector, and particularly in the maternal and child health subservice, one of which focuses on grievance redress mechanisms in delivery services. So this program is piloting particularly in the health sector, but we're looking also to expand to other sectors in education, social protection, etc. Should we manage to find good practices and develop good evidence for this approach. We are focused in northern Mozambique, Nampula and Manapa districts to be specific. Research is one of the main pillars of POTENCIAR, and to ensure the design and implementation and monitoring of program interventions, that they are evidence-based. The program commissioned a study to understand the system and practices of complaints and grievances in the health sector, particularly in maternity services from the moment they are made by citizens. The focus of the study on maternity services is because it's a critical service that health units offer, and violations in maternity service can have a strong negative effect on maternal mortality and socioeconomic costs for women. The specific objectives of the study were to map the flow of the reporting process, to understand the motivations, capabilities, and opportunities of health authorities to implement the system, to analyze how citizens' perspectives are perceived, considered, and rejected by health authorities, and finally, to capture the extent to which users use existing reporting mechanisms, as well as their motivations of existing opportunities to do so. So just to briefly outline the methodology, we won't get too much into it for the sake of time, but we did a document review, looking through legislation, through prior project documents, as well as other literature, academic literature on this topic. We conducted semi-structured interviews with key actors at the health unit level, and we also conducted surveys across 26 health units in these districts to understand how the management of user complaints was being conducted. The key findings, first of all, regarding the literature, what we found is that, at least in terms of the framework, we find support for GRMs, and the Ministry of Health of Mozambique recognizes the importance of participation and improving the quality and immunization of healthcare, and also defends the social participation of citizens with a view to improving health services. They see that citizen participation, or at least they state that citizen participation is a way of exercising social control over health services. MISA, or the Ministry of Health, also establishes that to ensure that primary healthcare is the entry point to the health system, and it is organized around the needs and expectations of people, not in diseases. So these are one of the statutes of the Ministry of Health. And finally, in the Charter of Patients' Rights and Duties, we find that the claim is stated that the patient has the right by himself or by whoever represents him to make suggestions or complaints about health services. So at least in theory, there is support from the government to establish grievance redress mechanisms in the health sector. we'll move on to what we found in the health units, which paints a somewhat different picture. So what we find here is that we've broken down here the types of grievance redress mechanisms that we were identified in the different health units. These include complaint and suggestion boxes, complaint books, telephone hotlines or helplines, user attention offices, and social welfare agents that may be tied to these offices. Then co-management committees for the quality and humanization process. These are communities that are embedded committees that are embedded within communities that sort of provide the link between the health units and the communities. I think in South Sudan these are like Boma communities as well, and telephone contacts with health unit managers or other staff within the health units, and finally satisfaction meters. What we found was that co-management committees and complaints and suggestion boxes are the mechanisms that are most used by health providers. In most health units, however, the users themselves say that they did not know about these complaint boxes or members of co-management committees or even the users' offices. So there is a discrepancy between what the healthcare staff or service providers state and what is actually the awareness of users of these mechanisms. All health units covered in Monapo district indicated having a box and a complaints book. In Nampula district, only 6 health units indicated having a complaint box, and only 3 indicated having complaint books. However, as we stated prior, most of these GRMs are also unknown to not just users, but even to the providers themselves, who did not know about any formal procedure to open the boxes. And they are also problematic because they require users to be literate and are located in plain sight, removing the anonymity in the process. Authorities, so regarding the co-management communities, these are also frequently cited mechanism for bringing up complaints. However, authorities and health providers make many assumptions about the linkages between co-management committees and the community. They are often spoken of as a link between the health units and the community, but in several cases they act mainly as helpers for health professionals and are almost confused with staff themselves. Telephone contacts were also frequently used or frequently cited. This is also made readily available. However, most health units were unaware of the existence of helplines. And there is also quite some confusion between helplines and the telephone contacts of authorities at the health unit itself. So here is where perhaps there's a blurring of line between independent and the service providers themselves. Finally, social media is increasingly, it was not included here in the list, but it was mentioned during the interviews as being increasingly used by users to try to create traction on the control, on the complaints that they've lodged. Finally, all health facilities are expected to have user offices with the purpose of informing patients about their rights and to receive complaints lodged by users. However, we only found 4 to exist in health units covered by our study, and their existence and purpose are little known even by health providers. Last of all, satisfaction meters are used to evaluate the satisfaction of user services with a traffic light system, green, yellow, and red. And they're a simple approach that is more accessible to users, especially to patients who are illiterate. However, these are often underutilized. So what we find is that there's a lack of information. There's fear and there's distrust and inequalities that characterize the relationship between users and these reporting mechanisms. although some users want to file a formal complaint, they do not trust the existing mechanisms. And therefore, they usually comment or complain among themselves or use informal channels instead. According to interviewees as well, the people who use the mechanisms the most are those with higher education or who are close to health providers, who have access to someone positioned at a higher level in the national health system hierarchy. While the people who are less educated are afraid and have little space to communicate their complaints. Both users and providers recognize that there is actually an importance and a need for the functional and reliable grievance mechanisms. Authorities are also aware that users do not feel comfortable presenting a complaint to health providers in person. They provide alternatives, but not everybody can make a phone call. Those who can will prefer to make the phone call and speak with members of co-management committees, or look for someone in the network who is connected to the national health system. Regarding knowledge of grievance mechanisms provided by health providers, there is some basic knowledge out there, but there's less knowledge within health providers as to how that should be managed, how complaints should be managed. There's a lack of guidance and training of health providers on the management of reporting mechanisms within health units. Some of the practices that were mentioned by staff about how health units manage these grievance redress mechanisms include informing users about their rights and duties. Although, as we saw in terms of the actual presence of user offices, this doesn't happen so much in practice. They often consult inpatients to discuss whether they have any issues. So these are conversations that are had whilst patients are receiving care. When complaints are lodged, there is a process of identifying the whistleblower, where they try to identify the person who made the complaint in order to settle it amicably and or verify the seriousness of the complaint, which, as you imagine, can it can be seriously problematic if that person wishes to remain anonymous, whether there may be repercussions. The subsequent step is that whistleblower has to identify the person who provided the poor service or who made an illegal charge. So they are often asked to point that person out, this limits the amount of complaints that are made because of the fear of repercussions. And often what happens in these moments are that the healthcare staff try to forcibly resolve the issue by requesting the whistleblower to give forgiveness to the healthcare staff, to ask for forgiveness, and then the staff must ask for forgiveness, and the whistleblower must give or forgive, so that the matter is resolved and they can close the books. Finally, staff also treat and file cases often as misunderstandings, even when, and this can happen when there's a lack of information, when there was some error in the document that they filled in, or whether there was a misunderstanding. So many complaints are often classified or misclassified as errors or are not taken seriously. So this is the practices that can create often a limitation for the process of the flow of grievance redress mechanisms to go through the system. In fact, even when we look at the health inspectorates, so those in charge or tasked to follow up on these mechanisms, on these complaints. Their focus is mainly on the technical components, or sort of the quality of service, but they don't actually focus that much on the complaints themselves. There's also a lack of depth and a requirement of the health inspection departments, and this is related to the degree that the national health system is involved in following up these processes. There's financial constraints within the health system, which means that even though there is an existence of clear terms of references, and in some cases the inspectors are trained to do the work with complaints, there can be a lack of human, financial, or material resources to carry out these inspection visits. In fact, we interviewed several people who said that the inspectors who had to pay for transport from their own pocket to be able to visit these health units. So to sum up, what we find is that although the study sought to understand the complaints and grievance management system of users within health centers, it wasn't really possible, because what we found was that there's no formally designed and executed process that's articulated with other levels of the system. On the contrary, what we identified was a set of similar informal practices that mainly aim to protect the health unit from external attacks. And these informal practices expose those who complain. Authorities and healthcare providers are aware that clients are not comfortable making a complaint to healthcare providers face-to-face, and both clients and providers recognize the importance of, despite them recognizing the importance and need for these grievance redress mechanisms to work. So to finalize, some of the recommendations that we put out in the study include to clarify the roles within GRM management, and to make sure that someone is responsible and accountable for closing the loop and providing feedback to complainants. We also suggest supporting the health sector or the authorities in clarifying the GRM process and drawing up guidelines that will cover the various levels of the national health system, such that it's clear to service providers and to users how complaints can and should be dealt with. Third of all, regarding the opportunities, we should improve data collection on GRMs through systematizing and normalizing the process. We have to also improve accountability measures and make sure that it's included in terms of references that certain people within the national health system would be, or certain departments would be responsible for following up with these. At the moment, that is not clear in the documents. Second of all, regarding capabilities, what we want to do is promote exchanges of experiences between within Mozambique and internationally, and that's what we're aiming to do with this particular webinar, and to understand which approaches, which mechanisms we could best use given the context, right? Given the fact that there are high levels of illiteracy, lack of assertiveness, and self-confidence on the part of complainants. We also wish to advocate for establishing a very clear GRM system that will be possibly overseen by civil society organizations in order to sort of make that process independent. However, the state still has to retain a certain degree of ownership of the system. So there's a balance to be struck. We recommend supporting training of providers and health authorities on the management of complaints. We also suggest to facilitate the systemization and dissemination of information regarding the guiding framework for citizen engagement within the health sector, particularly in complaints and grievances. We also suggest to promote greater interaction between the health inspectorates, the user offices, and the co-management committees at the local level. In partnership with civil society organizations, we suggest to also support the testing of the application of the satisfaction meter in particular by the co-management committees, because that will provide them with user feedback such that we can see how we can improve the usage of these mechanisms. Finally, regarding motivations, we suggest the promotion of mutual learning with other contexts that should include experiences that show how the strengthening of grievance redress mechanisms may have contributed to the improvement of working conditions of health providers and to increase the level of user satisfaction of the quality of services received. Then we should also improve the dialogue between users and providers and create a framework or a platform where that is possible, where dialogue is possible and lessons learned can be shared. We should also advocate for the anonymization of information collected in order to protect these mechanisms for colleagues who denounce other colleagues, for example. We should also support the Ministry of Health to adapt the existing performance management processes and integrate grievance redress mechanisms in those processes, such that it's in staff's terms of reference to be involved. And finally, we should understand or try to explore the reasons why grievance redress mechanisms are underutilized. This may be related to context. This may be related to the relationship with service providers and co-management committees that are structured in a particular way, which sort of perhaps incentivizes them to be on the side of healthcare providers and not so much the communities that they are meant to serve. So yeah, these are the recommendations that the study provided. We hope to learn from other experiences in other countries and see how perhaps we can contextualize these better and receive suggestions on how best to move forward with the platform that we're working on. Thank you very much.
Thank you very much, Ludo. Unfortunately, because we're running a little over time, we won't have time to do a specific Q&A after this session, but we'll bring in questions regarding the presentation Ludo made into the wider Q&A. I'd like to move as quickly on and bring in Dr. Suchi Panda. Particular thanks to Suchi, who is getting up extremely early in the US to join us today. Suchi is a scholar in residence at the Accountability Research Center, and her experience includes designing and implementing transparency laws in India, consultancies with international organizations working on open government, budget transparency and strategic approaches to accountability, leadership of action research initiatives at the Accountability Research Center, and these include social audit, citizen oversight, and her recent work on grievance redress mechanisms. Suchi's going to speak to today about her recent work reviewing evidence on GRMs from around the world, focusing on mechanisms attached to public services and programs in the Global South. Thank you so much, Suchi, and over to you if you want to share your screen.
Thank you, Annette. Thank you, Ludo and Alex, for the invitation. It's a pleasure to be here. And I'm going to be sharing findings which are from research work that I've done with two other people, Dumi Hussain and Anu Joshi. So our we're going to present basically research findings, so there's not going to be that much empirical case information here. We, over the last year and a half, have been looking at, GRMs because they were just popping up everywhere. We received a bunch of review requests about, GRMs and project level work. And so this, we were interested in like what's going on. And we did two initial sort of papers. Well, one was an initial review for the IDES A4EA program, looking at GRMs and conflict situations, and then we did a sort of wider public sector review of literature for the Open Government Partnership, which was looking at best practices for policymakers to draw on, and then we sort of developed what we were finding with GRMs into a paper, which is what I'm going to talk about today. One thing that jumped out at us very quickly was there was a lot of sort of conceptual sort of fuzziness around what GRMs are, and we saw that a lot of concepts were sort of being, there was a lot of overlap between like feedback and claims making and problem solving. And so we wanted to do a little bit of conceptual clearing before we kind of did a deep dive into the literature. And so, our focus came from the definition that we came up with, which is we were looking at institutionalized mechanisms that were looking at complaints of rights violations, but with the emphasis on providing resolution to those complaining. The focus of the literature, ended up being in the global South, because a lot of what we were finding in terms of empirical cases or project level or program level GRMs was emerging from the global South countries, and we decided to focus on public sector, even though the inspiration for GRMs, as we learned, comes from the private sector, from like customer feedback services and things like that, following the new public management wave. So even though there are definitional and institutional boundaries of GRMs, which will vary in different contexts, we did usually find that they tend to be of three common types. So there are government within government or administrative, there is independent redress institutions such as ombudsman's offices, and legal redress through courts, of course. So, why are we interested? What is going on with GRMs? And what we found was that they really are becoming, over the last 2 decades, a very prominent feature in the way that both governments, lending agencies, donor organizations are starting to look at how do you improve public services? How do you kind of, engage citizens in programs and public service delivery? And we saw that they were emerging around a range of political administrative systems, different regions of the world, varying economic development in those regions. And I mean, a few things that jumped out at us was that, obviously the World Bank, was making GRMs a key part of its citizen engagement work, and we saw a rise in, World Bank lending projects, including GRMs as an essential vital component of how they engage citizens who would be either using or affected by those projects. We have also saw that, at the national level, there was an expansion of legal and independent ombuds institutions, and governments are starting to see these as a way to gather citizens' opinion, to improve public projects, to improve government performance even. So we got interested in just, basically going through the literature and finding this kind of varied interest. So even though we find that there is a lot of interest in setting up grievance redress mechanisms, we're not quite clear about the motivations. And what we were able to infer from the literature was that there are 4 types there are 4 key motivations that could be driving this, right? So there's intergovernmental motivation, which is you want to exercise, one department or one ministry wants to exercise greater bureaucratic control over the other, and they set up a GRM, and that's one way of doing that. There are technocratic considerations where governments want feedback to improve public services, with or without the explicit sort of focus on resolution, even though they might have it in a policy or a project document. The third is the tapping of the democratic potential. So this I want to say is a potential that's claimed. It says if you do create avenues for people to complain, to voice their opinions, you will be able to better address their concerns and complaints, particularly those who are on the margins of society, so vulnerable populations. And but we are yet to sort of empirically establish whether or not GRMs could kind of live up to this democratic potential. And the fourth, I think, which was quite interesting, was that we're finding that governments are, on the one hand, you could see that, okay, there are champions within governments who want to listen to this citizens' voices, who want to improve public services. But there are also ways in which the GRMs could be used as surveillance tactics, right? So in some countries, we found that GRMs were being used to kind of tap into citizen opinion before it kind of erupted onto the streets in the form of protests, but popular protests that we've seen in the last couple of years. So on the one hand, we were finding that there is a great interest in GRMs. Governments want to listen to their citizens, but on the other hand, as we're all aware, governments are closing in on spaces where citizens and civil society can speak. So there's an opportunity to raise your voice, but there's, parallelly, simultaneously, there is restricting of free speech and civic space. So there is a paradox within which this proliferation of GRM is occurring. On the other hand, like I mentioned, this democratic potential of GRMs to provide more equitable and inclusive services and possibly even shift power in favor of powerlessness is the underlying kind of impetus that is being sort of suggested. But we are finding in the literature that oftentimes the institutions which will make these avenues available are all too powerful, and they would either ignore complainants or would just, the way that the system is set up, that you would just get lost in the maze. And Sarah Ahmed's sort of work on sexual harassment complaints in the academy shows that you tend to be, if you complain, you tend to be seen as a problem. You're not, your opinion or your voice is not necessarily what the policy or the legal framework says it is, that it's not. We're also finding that project level and program level GRMs, and the way that they're designed, especially in social protection programming, tends to kind of disregard or neglect complaints, especially if they fall outside of the purview of that specific program loci, right? So if you are dealing with a direct transfer or a conditional cash transfer program, as was the case with the Benazir Income Support Program in Pakistan, a lot of complaints were coming in terms of, am I eligible? Why am I not eligible for this program? And those complaints just slid off and were not dealt with. So who decides whether or not a complaint is legitimate and not, and how do you deal with a set of complaints that come up, which one person who is at the end of, who's at the GRM unit at that program basically does not have either the discretionary power or the authority to include those complaints. So what happens to those complaints? So in sort of looking at some of the other challenges that Ludo was referring to around state capacity in terms of going beyond awareness generation, but also to tracking and tracing complaints, and potentially with the intent of preventing those from recurring again. Citizen capacity to be able to access them, right? So some of what Ludo talked about is like, some of these are designed where they expected a certain level of literacy from complainants to be able to access them. Are all issues that came up in our review where there's need to both support the state capacity building, but also the citizen capacity building. And for us, what was striking was there is a silence, or sort of the role of third-party actors, in particular role of civil society in helping citizens access some of these formal complaint systems is understudied, even though they are doing a lot of the follow-up, a lot of the tracing back and and trying to get to the resolution. So I just wanted to sort of also flag those challenges there. So what we tried to do in our paper is that we're looking, when we started out, we were finding that a lot of things were being called GRMs, even though necessarily they were not. And so what we tried to do was that we tried to look at phenomena that we all know and hear of, which are adjacent to GRMs, but we're not really doing, did not include a whole range of practices which would let them, which allow them to be GRMs. So for instance, feedback mechanisms, we all know, are a way to invite both positive and public feedback, but they could be include general sort of issues and not be specific to complaints. Problem solving, is, a kind of a more reactive approach to, unforeseen challenges that come up and you want to prevent a project or a program from shutting down. And so you kind of, go into reaction mode and you try and solve that problem. But whether or not it leads to more systemic level changes is an open question. Claims making similarly is much broader. It's about rights and entitlements, but the difference that we're kind of making between claims making and GRMs is that the former is not necessarily sort of grounded in like rights or judicial precedent that recognizes rights. So you could be making claims for rights that are not yet recognized, but under GRM you're sort of basing your complaint on a particular law or a legal framework that kind of enables you to make that claim. And then last is accountability, and this refers to sort of the relationship between power and power holders. And we understand that the more traditional mechanisms of, administrative accountability, electoral accountability, legal mechanisms, but also, collective and citizen-led accountability or social accountability, these kind of look at the causal look at the causes of what's going on with a particular program or a public service. But we're more interested in whether or not they're getting to address more system-wide issues, right? So you might be able to pinpoint a problem that's happening at a project site or in a particular location, but what are the implications of that kind of reflecting upwards to kind of look at more systemic level issues? And we're not finding much evidence on that. So we said that there are certain things that need to be set out when you're talking about GRMs in order to say, okay, this is what we mean when we say this is a GRM. Or so it has to refer to complaints where people feel that they are mistreated, they feel that they haven't gotten their due, they might have a real or an imagined complaint, but it's based in it's a process of handling a complaint where you have backing, which is in public institutions under law. So like Ludo said, you looked at the documents that the health ministry has in Mozambique, and you found that there was an explicit sort of mention for citizen engagement. So yes, for participation and inviting complaints and suggestions. That's a good starting point. But then what do you go from there is to set up an entire process that follows through on that, which means how do you access that system? And Ludo's presentation pointed to some of the challenges of like risk of threat from revealing the information, the personal information about the complainant, or the complainant being asked to point out the person who he is blowing the whistle or she is blowing the whistle on. The third point is that complaints raised will have to have a clear process and possibility of resolution or redress. And this to us is key that separates, GRMs from all the other four sort of phenomena that I have highlighted is this idea of redressal or resolution, which is what a GRM, when you say grievance redress mechanism, the redressal aspect is key to it. And if that is not happening, then, we need to rethink, and we need to sort of call that process something else, because if there is no emphasis on redressal, then, we're basically back to calling it feedback or problem solving. Finally, we want to say that in the literature there was a lot of emphasis on ICT-enabled platforms, right? To use technology to kind of improve public services, to solve sort of governance and problems. But our understanding is that GRMs are not only about technical design, but they're also about power relations. And what we mean by that is that you need to empower citizens to be able to make complaints, but you need to simultaneously empower power holders, officials, to be able to respond to that complaint. Because if there is this gap between the higher levels who decide the policy and the lower level government officials or providers who implement it, there's going to be, the GRM is not going to be as effective if you don't have lower levels or local level officials with some amount of discretion and autonomy to respond to complaints, or to even divert the complaints that they think don't apply to their projects to a relevant authority. And that right now is not happening. So I just want to end here, and I know it's a lot of, we're summarizing over 200 documents from various places, but and I apologize that I will have to step off, but I'm happy to respond to any questions anybody has over email. So, thank you again, Annette and Ludo, for this opportunity.
Thank you so much, Suchi, and thanks again for fitting us in so early in your schedule. It's really kind of you. There aren't actually any questions in the Q&A, but I'll keep an eye on it until you're having to drop off from us. But as Suchi says, she does encourage anyone to drop her a line through email or social media if you've got any specific questions. And this presentation will be available on video for you to watch afterwards if you want to share with colleagues or anything. Thank you very much again, Suchi. So at this point, I'd like to bring in Dr. Tom Kirk. Tom is a researcher and consultant based at the London School of Economics and Political Science with the Centre for Public Authority and International Development. His interests include the provision of security and justice in conflict-affected regions, protection, social accountability, civil society activism, governance, and public authority. He has worked across a range of countries, but has particular experience in Pakistan, DRC, and East Timor. Today, Tom is going to speak about a grievance redress mechanism, which he designed with myself and Dr. Fayez for a UNICEF project in South Sudan. Over to you, Tom. Thanks.
Thanks, Annette. Thanks for that introduction. And thanks to the other speakers for setting this up. Touched on a lot of themes, which hopefully this presentation can bring to life a bit. I'm just going to put a timer on so I don't run over. Okay, so as Annette said, before COVID hit, we were employed by UNICEF to help them design a grievance redress mechanism for a big health project in South Sudan. The project was funded by the World Bank, and it was in their contract, as Suchi was saying, that they needed to have a GRM. I'm not saying that's their only motivation for having it, but it was hardwired into that. I'll talk a little bit about how this GRM was kind of done under the name of accountability to affected populations, which is a kind of discourse amongst humanitarians, or an agenda amongst humanitarians, to allow people mechanisms to complain. And it also feeds into this whole idea of embryonic democratic processes or social accountability. I'll tell you guys about the choices we made in the design of the grievance redress mechanism, and then I'll briefly touch on some of the data it collects and any lessons that we can start to draw from that. Just a bit of background for those who don't know. South Sudan is the world's youngest country. 2011, it was established following a 2-decade-old civil war in Sudan. In 2013, it erupted into civil conflict. Two main population groups led by the vice and proper president that conflict has caused huge amounts of internally displaced people and refugees. Even though there's a peace today, when we did this work, there was only an agreement to talk about peace, and there was still lots of conflict at the community level. There's also other hindrances. The country not only affected by conflict, but also periodic flooding, making it very difficult to move health supplies around the country in any systematic manner. We were basically working in Njongole and Upper Nile State, and we were working in both areas controlled by the de facto government at the time and the armed opposition at the time. The aims of the Grievance Redress Mechanism was to, the aims of the Grievance Redress Mechanism was to allow citizens a way to complain about the delivery of health services at 185 facilities. The facilities ranged in size from very kind of local health facilities, a couple of rooms, sometimes not even a full structure, all the way up to kind of larger facilities serving small towns. The idea was that we would feed into the government's own stated aims of providing mechanisms for people to complain and support something called the Boma Health Initiative, which was the government's program to set up kind of local health committees called Boma Health committees that people could go to with their complaints, and that would monitor the provision of health services, and their Boma Health Workers Initiative, which were kind of community health workers that go out into the community. We also had to feed in accord with UNICEF's own desire to allow people to complain safely and securely and anonymously about corruption and sexual exploitation by either humanitarian workers themselves or those within the health service. Just a little bit of background: accountability to affected populations is something that is an agenda that basically says humanitarians commit themselves to use their power of responsibility by giving people the chance to complain, raise issues, and hold themselves to account for the delivery of services in the places they're working. It's a kind of a change in mindset from affected populations being the beneficiaries of humanitarian aid or services to stakeholders and partners in improving programs and holding service providers responsible for provision. In a way, this really feeds into social accountability, and in places like South Sudan, some people argue that accountability to affected populations is a bit like an embryonic social contract between populations and humanitarians, and as with this program, where it feeds into what the state is doing and wants to do the state itself. The interagency standing committees had a bunch of guidelines on accountability to affected populations. They focus on setting up safe grievance redress mechanisms that are confidential, that are accessible by populations with different needs. In South Sudan in particular, very few people, there's very low literacy, very few people have mobile phones, even lower access to computers. These kinds of things have to be taken into account. These systems should be able to process data and use that to adjust activities of humanitarians in response. And there's a big emphasis on separating procedures for handling complaints and feedback that are about day-to-day service provisions and those that are about human rights violations, whether that be sexual abuse or exploitation or violence or others. And there's a need to, what they do, closing the feedback loop. There should always be communication between those receiving and handling the complaints and the people or populations making them, so people know what's happening. I'll skip through that. We began this project by doing some research, literature review, and we went out into the field and spoke to communities in both of the states. We came up with two kind of main challenges from that. And the first is that South Sudan, in many places, is what could be called a collectivist culture, whereas people who generally design AAP systems come from individualistic cultures, where complaining is something that individuals do and they expect their grievance to be resolved. In collectivist cultures, people can tend to be much more private about raising complaints, solve it through personal relationship structures, and the emphasis is often on social harmony than rather some kind of redress for an individual. The second kind of challenge we had is that in South Sudan, many people just don't know their rights, either under the new government or vis-a-vis humanitarian. So there was a real need to kind of raise awareness about that. We also mapped stakeholders that we could possibly engage for the system, particularly with a focus on the community level. And here we tried to look at the disadvantages and advantages of engaging different types of stakeholders. And South Sudan, generally people are represented by chiefs, but there's also other types of leaders, religious, women's and youths, and this new section of stakeholders made by the Boma Health Initiative. So we decided that we needed a multi-pronged system. We needed multiple ways that people could raise complaints, both for safeguarding people's identity and because of those challenges of a lack of access to phones or email or low literacy. And we're also very aware that there's a huge amount of local politics. So people quite often don't want complaints to be public. That can lead to spirals of violence, accusations. So we really needed many kind of channels in which people would lodge complaints, and we set about designing a system with 5 channels. I'm just going to go through those. And there's a system in a whole. I won't dwell on this. It basically shows that complaints can be raised by the community and the 5 streams we have for raising complaints. The first stream was the Boma Health Committees. These are the committees of community leaders. They were already community leaders, as in local chiefs and sub-chiefs were always on them, but we worked to ensure that there was also female representation and women's leaders on these committees. We set about designing a training program for these leaders so they knew how to handle complaints safely and safeguard the identity of complainants, particularly when the issues were to do with sexual exploitation or corruption. Our second stream was through the Boma health workers. We trained them to record complaints in what we call Boma health workers' diaries, and particularly to try and pick up on rumours about the provision of health services or patterns that they were seeing in the communities. Boma health workers are meant to and are instructed to visit up to, I think it was 42 houses a week anyway. So we were just adding a little bit of additional complaints gathering to their daily work anyway. As I was saying, we tried to ensure that women were represented on the Boma health committees. And in particular, we tried to train older women to be what we called accountability to affected population champions, with the idea that women who were reporting sensitive complaints would want to report them to women rather than the men on the committees. And we also gave them ways that they could link up directly with the implementing partners of the program, thereby bypassing other methods if they felt complaints were particularly sensitive. Our fourth stream was to work in the health facilities themselves, where we trained particular health workers working in the facilities to be focal points for handling complaints. We also made sure there was recording procedures, big books with a double-sided paper, so all complaints were recorded twice, and we trained all the implementing partners. I think there's 18 implementing partners on this program, a mixture of INGOs and NGOs, on how to take those complaint registers and turn them into data that could be actionable and used. And then our last complaint stream were annual community health dialogues, and this is where our AAP system kind of moved more into social accountability. And these were essentially annual parties around health centres where communities could come and speak to authorities, whether they be health workers or members of UNICEF's programme, and raise their grievances and complaints with them, but also praise the relevant stakeholders when they'd responded to complaints and well. And this is where these kinds of systems tip into that kind of building relationships between populations and stakeholders and states and what have you. So just a little bit of a note before we end on the system in action. I've only got data till July 2001, but you can see that there was quite a nice spread of the way people were raising complaints or the channels that they were using. Our women's champions, which hadn't been a thing before this program, were being used. People, as expected, were using their Boma health committees, but there was also a lot of complaints being raised directly and with the Boma health workers, which was quite unknown to us. In terms of lessons learned from this, I think where our GRM really had a grounding and secured buy-in was by piggybacking on the existing Boma Health initiative that the government was keen to push out. In terms of challenges, though, there really was a challenge in terms of raising awareness with people about their rights to complaint, because for a long time they'd been used to services being provided by both the state and humanitarian organizations. So it's very confusing for them to understand lines of responsibility. So a lot of our work was socializing people around the complaints process and who is responsible for what and when. Another lesson, multi-channels. I think our early data collection showed that you need multiple channels, especially in contexts where the identity of the complainant, especially around sensitive complaints, really needs to be safeguarded. The data also showed that beyond addressing complaints, these systems can often be early warning systems, and they allow programmers and governments to identify major trends, rumors about the provision of health services, or in the case of Sudan, where local health facilities may have been captured by particular political groups or parties, or even the systems can get captured themselves. So people by people who use them to express frustrations with other things other than the health system or health services. Lastly, a bit like was alluded to in Suchi's presentation, throughout the design of the system, there was definitely a tension between the need for the system to collect complaints and resolve them, and to protect the program and the institutions involved in the program itself, and with UNICEF wanting to use the system to monitor their implementing partners on the grounds. These three things kind of stood in tension to each other, throughout the design of the system. I'm not saying you necessarily have to resolve these tensions, but there has to be a realistic conversation that GRMs aren't just about resolving complaints all the time. And then lastly, the thing we found in the early data we were collecting on complaints collected was very few of the complaints were having the loop closed, and this means there was little evidence of stakeholders going back to communities and telling them how the complaint's been resolved, and then communities themselves saying, well, we agree with that, thank you very much. It really suggests that the emphasis, once systems are up, has to be on closing those loops and allowing communities themselves to provide evidence that the loop has been closed, and not just listening to the stakeholders, or sorry, not just listening to the service providers, so to speak. Okay, that's the end of my presentation. Thank you. I'm sorry I ran a bit over.
Thank you very much indeed, Tom. Really great to have some of the examples of how some of the challenges that Ludo and Suchi identified from the research and the literature can be overcome by ensuring that a mechanism is very closely designed for the context it's in. That's really great. I'm now going to bring in Dr. Fires to talk about the project in Pakistan. Just for a little bit of context, some of the learning from the project in Pakistan was used in the design of the South Sudan program. So you may see aspects of similarities and then other differences as well, just to give everyone a little context there. We did receive a question while you were talking, Tom, but I'm holding it for after Dr. Fires' session, because I think there's some things he's going to say that are relevant to that question as well. So just to bring Dr. Fires in here, Dr. Fires Ahmad was the team leader of the 5-year Empowerment, Voice and Accountability project in Pakistan. He specializes in health system strengthening and social accountability, working across a range of countries, including Kenya and South Sudan for the last 25 years. He's currently a freelance consultant based in Pakistan. Dr. Fires is going to speak today about the different approaches taken by the EVA project to grievance redress, complaints handling, and increasing responsiveness to citizen voice. Over to you, Dr. Fires.
Thank you, Annette. And how much time I do
have? You have between 10 and 15 minutes, Dr. Fires.
Thank you. And so I'm taking thank you to Tom and Suchi and other colleagues for presenting it. Ludo, EVA is now closed. This was Empowerment, Voice and Accountability Project for Better Health and Nutrition. The project closed in 2019. and we are just presenting what happened. So on AWA, it was natural. What we learned was the GRMs, yes, they work, but I really rarely, considering all the issues mentioned by Tom and Ludo around the sensitivity of the information, around the processes in which that information should be managed. So it was a component on AWA, but we didn't take it as a route for our improvement of citizen services for the citizens. And for the citizen voices, we use more open and transparent forums where the citizens and the decision makers were sitting together in a cordial. And what we learned over the 5 years is that actually there is willingness on both sides. There is no suspicions. Both sides want to raise issues and resolve issues together if they are given that opportunity. So we had a very complex theory of change for the project, but in very simple words, if citizens are organized and aware of their rights, and they have the opportunity to raise their voice with the decision makers, then the state will respond. And maybe the journey down the line, very few things which I will want to mention in these 10 minutes with you is the learnings we did and the achievements we have, some of them as a result of this. So one of the theme which Tom touched upon is what we say, and I will use Jonathan's framework of taking scale into account. That for any accountability or service, social accountability activity, we need to make sure that the barriers at different levels are touched upon. And I say when there was a question related to that as well. So when we started the project, we looked at the health, the mapping of the health system. There's a community level, a health facility level, then there's a district government, and then there are provincial governments. Since Pakistan is a devolved state, we didn't have a lot of federal or national level, but some of our activities touched upon that level as well. And decisions are taken at all these levels, and we wanted to establish, number one, organize citizens, number two, make them aware of their rights, and number three, provide them the forums where they can engage with the decision makers at that level, in all these levels. The other point, so this is taking scale into account that, yes, if budget is not allocated, what can a doctor do about the medicine availability in that health facility? And issues like this we had a lot of discussions. On the left side, you can see that in order to amplify and protect citizens' voices, we mobilize citizens, allies, and they included media, religious scholars, and elected representatives. But even within government, there are many institutions. One example is the Healthcare Commission, whose role was to regularize the health services both from public and private sector. And when we engaged with them, they were working on responsibilities of patients when they go to the hospitals. What are their responsibilities? And we engaged with them to tell them, okay, besides the responsibilities, maybe they have rights as well, and those rights should be also communicated to health workers that these are the patients' rights. The other, when you look at your environment or map the territory, you will find a lot of very powerful allies who are mandated, who are committed, who have established systems, and they have legislative and legal backing to their work, and we engaged all of them. The second thing was that for this engagement to be effective, to be not based on suspicion, to be not contradictory and in a fighting manner, we introduced the concept of community-based monitoring. So in community-based monitoring, the citizens will go and check various aspects of healthcare provision, and they will gather that data and present it to the health worker, first of all in the same facility, and then collectively at the district level, and then collectively at the provincial level. And this is an example of how this community-based monitoring was done by citizens. They were doing interviews. For example, in Pakistan, when you talk about improving service delivery, then it should be not only the quantity, but also the quality. We have more than 90% and 95% antenatal coverage. But when we look in the area in the middle, you can see very few people, women were weighted, some were vaccinated, some urine test was not done. So if I do an antenatal care where blood pressure is not taken, woman is not weighted, and urine test is not done, so probably I'm going to miss that mother. We won't be able to save her life with the whole concept of antenatal. And this generated a very interesting discussion with the health staff. And these are the things which we continuously worked on. Similarly, for children, they were coming for growth monitoring, but you can see only 65% of them were, they had their mid-upper arm circumference measurement done. So then the quality becomes the ultimate objective of why we are doing these activities. Yes, we can count numbers in terms of quantity, but what is the quality? So community-based monitoring was the second learning. So the first learning for us was taking scale into account. Second learning was to have a meaningful conversation. You have to have an anchor. And in this case, it was community-based monitoring. Third was that when there was a discussion, we continuously followed it up, how this discussion was happening. So on the left, you can see we were monitoring who were present in a district forum. And you can see that we had all the right people coming to the district forum where the citizens and the decision makers were making those decisions. So we had parliamentarians, we have religious media representatives, civil society representatives, communities themselves, and then the policy decision makers. And when we started the project the first year, we had only 36 of the complaints resolved or issues identified by citizens as priority. Only 36 were responded by state. But you can see over the years, then this continued, and we were receiving some very serious results, although they will count one, but there were even provincial level legislations which applied to the whole province, and it was not a simple BP set is broken and repairing. So we saw that evolution of how this interaction can improve the system. Second was that when issue was raised, let's say at community level, then the citizens at the end, towards the end, they also knew that where they should refer it. For example, issues for 3,500, 6,000 were raised at community, and then of these 6,000 issues identified, 3,500 went to the district level, and then around 400 of them went to the provincial level. So we kept the issues. We also had even a database where citizens will tell us how many times they have raised this issue at various forums and over time as well as in different forums. And then the end is just a few pictures of one is already written by Tom. Some other places where we have the project was measured. These are available online. So these are the 2-3 things which I want to share clearly of a 5-year project which we lived together. These were the 3 major lessons which I wanted to share with you as a practitioner. Taking scale into account, using data properly, and continuous follow-up at the forums which are appropriate.
Thank you very much indeed, Dr. Fayez. And I should say also special thanks to Dr. Fayez for joining us, because he's actually on annual leave this week in the lead up to Eid. So we're very grateful to have you with us. And thanks for giving up some of your leave time to join us. We've got a couple of questions which I'm going to bring in now. So a question from somebody actually who works on the POTENCIAR program, Kathy. She asks, and this is probably a question mostly for Tom and Dr. Fires, to what extent can the nature of complaints be addressed by health professionals given the structural constraints associated with health budgets and other challenges that health professional staff face? Is there an assumption that if health professionals are unable to respond because of constraints, they will join in collective action with citizens? What is the evidence on GRMs implicitly naming and shaming in ways that might undermine these relationships and the potential for this? Tom, did you want to come in on that? And then I'll come to you, Dr. Fires.
Yeah, sure. So thank you for the question. In the context of South Sudan, the truth is the vast majority of the complaints that were raised in those initial months were what marked as unactionable, in the sense that health professionals weren't able to respond to them for the reasons you say. They didn't have the budgets, they didn't have the resources. Quite often the complaints were related to lack of facilities or supplies at the centres, which was UNICEF's job to deliver them there. These things are out of the control, often for health professionals. But what the system allows, especially if you're closing the loop, is to have a dialogue about that with citizens. So instead of populations feeling that they are being ignored or that something's going wrong, they can raise a complaint, and health professionals can sit with them, whether it's members of the Burma Health Committee or people themselves, and explain, like, look, this is out of our control for these reasons. We are looking on it, we're on it. It allows that kind of beginning of a relationship to come. In terms of naming and shaming, I can't really speak to that too much, but I don't think naming and shaming is always a bad thing. I think in some reasons, the whole point of accountability mechanisms is that we're shining light on things that are going bad, and we're putting things into the public arena which were often not talked about. Obviously, we don't want to be naming and shaming when the issues are of a sensitive nature, sexual assault or corruption, until proper investigations have happened. But naming and shaming is kind of hard built into these systems in a sense. And I don't think we should necessarily always see that as a negative.
Thanks very much, Tom. Dr. Fires, did you want to come in on that point as well?
So from my side, again, as mentioned, citizens, first of all, they learn. We saw their evolution from starting with we want highly sophisticated machinery and a very basic health unit, to a situation where they were actually leading the ministry in terms of policy changes. So the citizens have to go through this journey, understand what their rights are, what the government has committed to them, and if it is not met, what are the channels in which they can go, and if they need to do advocacy, who they should reach out to. Generally, they know all these things, but when you organize them in this way, then it can work. Naming and shaming, again, for me, if it is done through media, if it is done through powerful citizen allies, it works. But if you put communities into, then you need to make sure that they are protected as well. Those voices are protected as well. Third is, what are your basic assumptions? For HIWA, what we learned was the basic assumption that yes, there are some unwanted interests, but generally the majority of system on both sides is eager, on citizen side as well as the supply side is eager to resolve these issues. If we establish all the mechanisms where we want to put controls on these things, and we consider everything coming from a wrong perspective or with bad intentions, I don't think then we end up having GRMs, but we don't do social accountability as such. And GRMs have yes, a lot of potential, but I don't think they have a big potential in social accountability. My personal opinion. Sorry.
Thanks very much, Dr. Fires. Tom, did you want to come back in?
Yeah, I did. I mean, it just strikes me that a different context, the kind of idea that there's a conversation between service providers and citizens can have totally different ramifications. In a place like South Sudan, when services aren't delivered and expectations are raised, people can come up with and do regularly quickly politicize those issues, and it can quickly turn violent. People can think that their community is being ignored by the state or humanitarians for political reasons. People can accuse particular service providers at a local level of corruption or doing something wrong, and that can spiral into cycles of violence and community conflicts. So by having a system, even if the complaints can't be resolved, to allow dialogue around issues, it can really have a useful effect in that sense of like getting that talk going, squashing rumors. And I know that's far away from resolving a complaint and having everything done, but for me, that's a really important function in these very challenging contexts.
Yeah, I completely agree with you there, Tom. I think just to add to something Dr. Fayez said, something I found really encouraging on the EVA project was when groups of citizens were equipped with information about what could be resolved at different levels and almost most importantly, what couldn't be resolved at different levels, we found they were more likely to join in partnership with health workers in identifying what the particular challenge was. So to give an example, if people in a particular area were dissatisfied with the number of hours that a health facility was open or the number of staff that were available to see them, if they had armed with the knowledge that the provision of staff to a particular location was not in the grant of the health service providers themselves, but was a decision by higher levels even than the district government, they weren't going immediately to health service providers and making that complaint to them because they were aware in advance that there was nothing that the health workers could do about it. Instead, they were asking them, is the reason the health facility is not open beyond X number of hours because you don't have enough staff? And say the answer might be yes, then health workers and community were coming together to identify what needed to be done to fill the problem of the health facility not being open as long as people wanted. And then those complaints could collectively be taken to the levels at which duty bearers had the power to actually do something about those. And we often found as well that duty bearers were more likely to listen to complaints if they were backed up by service providers themselves also saying, yes, we agree this is a problem in this area. So it gave added weight. But again, it hugely comes back to what the relationship between providers and kind of service users is, as Kathy points out. I just want to, in our last sort of minute, bring in a final question from Chris. Chris has said, can we have an online system that can capture all of this in case an organization wants to do monitoring? I'm going to unmute Chris to allow him to expand on that question. Chris, have we got you there?
Thanks a lot for giving me opportunity to speak. My question is that many a times we find it very expensive to conduct this monitoring. What I wanted to know is that if we could have an inbuilt system, either that does not use internet, that citizens can use whenever they go to facilities from time to time, so that they can file the complaint, and this complaint can be instant or can be synchronized and be used at different level for addressing the complaint. Therefore, it comes with element of sustainability, and also community can be using it on their own without necessarily having CSOs to stand alongside them. And also the government itself, if you get a progressive government, can adopt the same system so that stakeholders can be meeting from time to time to engage on the outcome. Thank you.
Thanks very much, Chris. Appreciate it. Tom, I'll bring you in there.
Thanks, Chris. Yeah. So in South Sudan, as you can imagine, there's clearly not internet services in the majority of the country and places we are setting up the system. So our system was completely word of mouth and paper-based until you got to the level of the implementing partners. So both the BOMA health workers and the health facilities had books. What do you call that paper where it's double-sided? I can never remember. Basically, they had to duplicate all of the complaints and record them on paper. And these books
carbon copy paper
were collected on a monthly basis by the implementing partners of the program. And because there was 18 of them, they were quite spread out over the country. And from there, the complaints would be digitalized. So they'd be put on a joint online Excel spreadsheet that could pump out graphs and allow monitoring in not quite real time, but almost real time. And it was the job of the implementing partners to go back to the health facilities and the various channels for complaining and ask for status updates of the complaint, and then update their online system. And that information was passed digitally up to UNICEF and shared with the local, with the Ministry of Health. So both of them could have oversight and see what's happening. Our main concern there really was to ensure that there couldn't be any falsification of complaints, and this is where the carbon copies came in useful. So if there was an issue, you could go back to the originals, but also just that sheer amount of data allows you to spot trends. You could see in certain areas where, for instance, people were claiming or partners were claiming that all of the complaints were successfully resolved, or there was no complaints. All of that allows a good data analyst to spot potential issues or where the system might not be working in time. So yeah, it's possible to do these things, I believe, without internet all the time, and get as close to as possible real-time incoming data.
Thanks very much, Tom. Dr. Faiz, did you have any last thoughts you wanted to say on that before we wrap up?
No, I think I agree with what Tom said, and also this interaction between people in the same room is always more effective and creates a goodwill compared to an online system where it's not so powerful.
Agree. Well, thank you very much. We're out of time now, and thanks to everybody who attended. All those who registered for the event and did or did not attend will be sent a link through to the video of this if you want to watch any more, and do share across to colleagues and those you know are interested. Huge thanks to our panelists today for making time and joining us for this. And those of us at POTENCIAR will be taking a lot of what was discussed forward into the work we're doing in Mozambique. So thanks very much to everyone, and enjoy the rest of your days. Thanks.
Thank you. Bye.